So my topic today is study design and planning, and my agendas are type of study design, population selection and sampling of the population, some introduction on sample size calculation, and issues in research related to low and middle income countries. So today morning we discussed why we want to study research. That was a pertaining question. There is a formula called 99-1 in internet. That is, in internet 90% of us are viewers, 9% actually do some interaction like comment or do something, and 1% are only the creators. So in research also it is the same. 90% of us will be the consumer, we will be reading research paper. So we need to study research methodology to understand the research paper, which is filled with lot of jargons. And 1% of we will be researcher, and I will be happy if some of you become a researcher. That will be great. But basically we need to study research methodology to understand others' research. So when you are in a clinic, patient have lot of questions like, how long will I live? Doctor, I have cancer, how long will I live? Is this new immunotherapy drug really worth it? Is really worth the hype that you see in the newspaper? Will it help me? What is the best treatment for my condition? Will my cancer again come back after the treatment? Is the 3-drug combination better for me than the old 2-drug one, or is it only going to make me more sick? Or which treatment option gives me better quality of life? These are the type of question our patient will be asking us in OPD every day. And to properly answer it, to scientifically answer it, we need to have well-designed clinical research which can answer the question that our patient asks us. So research in healthcare can be of different type, like it may not involve the human also. It can be preclinical research in cell line or mouse model. Clinical research, when we say clinical, it means in a human volunteer, or it can be field research like epidemiological research, field studies, this sort of things. So how do we broadly divide research is observational study and experimental study. The difference is, did the investigator assign any exposure? Exposure is a jargon. If you give any drug, if you do any intervention, if you do any type of surgery, everything is exposure. So if the researcher is just observing, not disturbing the system, it is observational study. If the researcher is actively doing something, then it is experimental study. So coming to observational research. Observational research can be broadly divided into descriptive and analytical study. Descriptive is in which you describe the data in one or more characteristic, like you are not trying to answer the question on the relationship between different variables. For example, you have a group of 20 patients, you observe different type of things on them, like their age, their what problem they are facing, something like that, and you report it. You report it in form of case report or case series. These type of studies are called descriptive studies, and they are also research, like we discussed in the first session. Now coming to analytical, here you are going to do some, you are only observing but doing some analysis. Why do you do analysis? To find cause and effect relationship, to explore that if there is any cause-effect relationship. The researcher tries to find out the effect of exposure on the outcome. This type of study are like cross-sectional study, case control and cohort study. I will be talking about this. So cross-sectional study is like a snapshot. You take a population, you do a research, you measure the finding at one time and see what is the current status. You don't go back to the history, you don't go to the future. Like we survey 1,000 adults to check if they smoke and if they have high blood pressure. So in this study there is no follow-up, no looking back. It is good to find prevalence, like what is the prevalence of hypertension in a random 1,000 patient. It can't prove causation. It can show that prevalence is high or low, but it can't prove any causation. As I said, in cross-sectional, we are collecting data at one point of time. There are other studies like longitudinal studies in which you can take repeated data. For example, in case control study, what is done is researcher select a certain case and he tries to who has a disease or certain outcome and tries to find the similar patient, like similar age, similar, so many different variable he may have chosen, and try to find the similar cases and try to see what is the difference between group which has a disease and group which does not have a disease. So these are backward directed studies. The patient already has outcome and the researcher is trying to go back and find what is causing it. Outcome has already occurred, and the most important thing in case control study is selection of the control arm. So if your control is not good, this is not going to give a good result. For example, the research question is, does eating junk food cause acne? This is the question. So the cases are teenagers who already have acne. The control is the teenager who don't have acne. Similar population, but they don't have that problem. So he asked both the group like how often they are eating junk food, and he tried to find if there is any link between acne group and junk food group. Case control study in the end will give you odds ratio. Odds ratio is nothing but the risk of having, the chances of having this condition. I think it will come in the stats which is coming on, but case control study ends with odds ratio. So now coming to cohort. What is the meaning of odd cohort? Any volunteers?
A group of people with certain characteristics in which we are trying
You can sit and say.
a group of people with certain characteristics that are the subject for our study.
Okay. Any other volunteer? She is more or less correct. Cohort actually is a military term. In Roman army, there was a group of 300 to 600 army. They were called cohort. And usually in a group, they share a common characteristic. So it comes from the military terminology. But in cohort, what you do is you take a group of patients and follow up. It is a longitudinal study in which you follow up over multiple time and see the exposed and non-exposed group and try to find any difference. So it is a prospective study, like we take a group of patients and go to the future. But there is something called retrospective cohort. So it is not always necessary that cohort has to be prospective. In retrospective cohort, what you do is you take a patient who already has the condition and try to go back in the history and find what is the difference between those two groups. Like you take a hospital record from 10 years, divide into smoker and non-smoker, and see over 10 years who have developed lung cancer. So this is like cohort, but it is easier to do because you don't have to wait in the future. It is less time consuming. So let's talk about the timeline of different study. As we discussed, we are in the present. In cross-sectional study, we just observe what is at the present. We select 1,000 patients and see what is their blood pressure. So we are not going into their past, we are not going into their future. In cohort study, we select the patient now. We take a group of patients and follow up them for suppose 5 years and see what happened to them. Retrospective cohort, as we discussed, similar to the principle is similar, but you go to our past. Case control, you select the patient cases, select the control and look at their past history. Randomized trial, it is always you select the patient in the present and go towards the future.
Implementation study comes in cohort.
What?
Implementation study.
I will come. Implementation, I will be the last. So let's take some example. You do survey of 1,000 adults to find how many current smoker and how many currently smoke and how many have oral cancer. So what is this study? This is cross-sectional study because you have measured only once. You follow 5,000 patients with BRCA mutation and 5,000 without BRCA mutation, and in 10 years you see how many develop breast cancer. Prospective cohort, yes. compare prior radiation exposure in 200 patient with thyroid cancer versus 200 without thyroid cancer. Case control. Good. Compare 300 patient with glioma and 300 without glioma brain tumor and assess their mobile phone usage pattern. Yeah. 15-year follow-up of 10,000 teenagers in Bhaktapur, about half of whom are smoker, to monitor who develop lung cancer. Cohort study. So by now you have idea of what is cohort study, what is case control, and what are the sample size in cohort study and how expensive it is going to become. I think we all are familiar with level of evidence. The higher you go, the evidence are more robust, they are more reliable. And if you see the case series, case control, cohort, they all come below randomized study. So they are not as good as experimental study. Why is that? It is because the robustness of observational study is much lower compared to interventional studies, because there is no randomization, so there are a lot of biases. There is no control, really control over exposure. You are not changing the system, you are just observing the system. There is no control over timing of disease status measurement, no control over exposure to other risk factor. So all these are the weaknesses of observational study, and that's why we need the experimental design. So coming to experimental study, I think you have seen this picture. So what is this, a causation or correlation? So everyone can volunteer. Is the bird causing it or there is a correlation? So it is neither causation nor correlation, it is a coincidence. So this is nothing but English language. We have to understand three terms: correlation, causation and coincidence. So what is correlation is two things are occurring together, but we don't know why. Like there are some papers saying that if you drink more coffee, there is decreased risk of Parkinson's disease, but we don't know why. Causation is very simple. One thing causes another, and the classic example is smoking causes lung cancer, which every one of us know. Coincidence is there is a link by chance. For example, when there is increased sales of ice cream in Kathmandu, there is increased cancer rate in Kathmandu. So it is by chance. If we see Venn diagram, causation is a subset of correlation. For causation, there should be correlation. Coincidence is something different. To prove causation, you need experimental data, like randomized trial. It may not be 100%. Sometimes you can do ethical experimental studies. So there are some strict criteria in which observational data may suggest causation, but the rule of thumb is to prove causation, you need experimental data. Correlation can be seen by observational data, which we discussed. Coincidence, the role of statistics is to filter out coincidence. We will be studying all the statistics today afternoon to filter out all the coincidences, which are like the errors. So when we are talking about experimental data, we are mainly talking about clinical trials. Clinical trials are nothing but you are testing intervention. It can be any form of drug, it can be any form of surgery, any other treatment, any lifestyle changes, it can be anything, properly, rigorously, in a scientific manner. And it is divided into different stages, which is classically called phases of trial. So when you say clinical trial, it starts with human. Before doing human study, you have to do the study in some experimental model, like mouse model, or in computer like simulation silico model. It's different. These all are preclinical trial. These are not clinical trial. And the first phase is phase 1. In phase 1, what we do is we take a small number of patients and we try to see if this drug is safe and what is the dose for proper dose for this drug. In this phase, we are not trying to see if this drug is good for the patient, if this drug is better than another drug, nothing like that. We just try to find the suggested dose for phase 2 and the safety signal. In phase 2, what we do is we take a bit bigger number of patient and we try to see the response rate. If suppose this new drug is giving around 30%, in 30% of the patient this drug is working, or 40% of the patient this drug is working. So this is phase 2, and new signal like the side effect which was not detected in phase 1 may come in phase 2 because you are giving to more number of patient. So when this drug passes phase 2, like we suppose the new drug is working in 70% of the patient you are giving, so you think that this drug is better than the drug in market or it is similar, you do a phase 3, the randomized phase 3, the gold standard of the clinical trial, in which you compare the new intervention with the which is already established. So it is usually done in larger number of patients in different centers, and most of the drug regulator, when they approve new treatment, they require a phase 3 trial. Phase 1 and phase 2 data is usually not sufficient to establish the new drug. And phase 4 is after it goes to the market. Most of the pharmacy people, they know better than us how the post-marketing surveillance is done. When large number of patients are getting that drug, new safety signal may come which was not seen in clinical trial. This is phase 4. So the one question, why we need to do all this? So I have got a good drug, why don't I start this good drug versus the current standard and do phase 3 trial?
We need to see safety first.
Yeah, one thing is ethical. It should be safe in human, it should be working, it should have some data. Then only you can do this thing. It is not ethical to bring any new substance and do a trial comparing with the standard. Many alternative medicine, mainly Ayurvedic people, what they are trying to do is they want to start a phase 3 trial without having preclinical or early phase data. This is not the proper way of doing it. And another thing is the cost.
Drug resistance also.
Another thing is the cost. Like the higher you go, it will become much more expensive. So you want to stop the drug which is likely to fail in early phase so that you don't spend a lot of money for the pharma company. Like in school, what they do is they do the pre-test and only then the student can give SEE. So the school results become better. Similarly, if the drug is not doing that good in early phases, they won't take in phase 3 because the phase 3 is very expensive. And if it fails, then a lot of money is gone. So this is why all these steps are done. So this is a recap. In phase 1, what we do is this treatment safe? What is the safe dose and identify side effect? In phase 2, is this drug effective? Like how many % of the patient it is working? Then only comes the phase 3, where you confirm the effectiveness and you compare with the other treatment. So phase 3 will make or break a intervention. And phase 4 is post-marketing, you do a post-marketing surveillance. So let's look at a real life example. There's a new drug called 𝗦𝘂𝗯𝗵𝘀. This drug works in small cell lung cancer. So what they did is, this is a, which phase is this paper? This is preclinical because it was done in mouse model. So first you have to prove in mouse model that this drug has efficacy, and the result is this drug showed safety and efficacy not in human, in mouse. So now this drug can move to clinical trial like phase 1, 2, 3. So let's follow this. So now this drug got a new name, tarlatamab. This is a T cell, let's forget the details. So what they did is, after the successful phase 0 preclinical study, they went to phase 1 trial. Why did they do phase 1 trial? To find the dose. They started from 0.003 and went up to 100 mg because it is a new drug. We don't know what is a good dose for this drug. So the conclusion is the safety profile is good, toxicity is good, and they suggested a dose in which phase 2 should be done. All the phase 1 study with this finding only. phase 1 does not establish that this drug should be given to lung cancer patient. So if you are practicing doctor, you should not change your practice based on this type of study. They have their specific goal. So again, the phase 2 of that drug was published. So in this phase 2 they involved more patient. They gave the dose which was suggested in phase 1, and their result is it has anti-tumor activity with durable observatory response, and there were no new side effect. So phase 2 gives us how effective is the drug in a group of patient. There is no comparison group, and is there any new safety signal, because you are giving to the more patient compared to phase 1. So this drug successfully completed phase 2. It was published in a reputed journal, New England Journal of Medicine. Then this drug went to phase 3. So let's see, this is the phase 3 study, again published in the same journal. So what they did is, now they are doing multinational study, because you need a lot of patient, you need a different group of patient to prove that this drug works not only in one category of patient, it works in all different ethnic, race and racial group. And they found that the conclusion was this lead to a long-term overall survival. First time we are seeing that this drug improve overall survival. It was not seen in any of the other phases of trial. So this is how any drug, it is not only drug, any type of treatment or intervention, it goes from the lab to the patient. So with example, we have seen that how these drugs move through different phases and they come to our clinic. So after phase 3, the regulator, they grant the approval for this drug. So now this drug is approved for treatment of patient. Now let's come to the second part of the talk. We have completed the first part, that is the population and the sample. So any questions so far? We can discuss.
phase 1 मा चाहिँ हेल्दी भोलिन्टियरमा गर्ने हैन र हामीले अनि क्यान्सर पेशेन्टलाई कसरी थाहा भयो कि त्यो क्यान्सर पेशेन्टमै राख्नु छ भने त हामी फेज उसमा के रे सेकेन्ड या थर्डमा गइसकेपछि मात्र तपाईको पेशेन्टमा युज हुन्छ अथवा नि हेल्दी भोलिन्टियरमा हुन्छ भनेपछि कसरी थाहा भयो?
भोलिन्टियरमा हुन्छ. फेज 1 क्यान्सर ड्रग चाहिँ युजुअली हेभिली प्रिट्रिटेड पेशेन्ट इन विच देयर इज नो अदर अप्सन, त्यसमा हुन्छ. जुन पेशेन्टलाई अरू ट्रिटमेन्ट क्यान्सर भइसकेको छ, अरू ट्रिटमेन्ट अप्सन छैन, त्यो पेशेन्टमा चाहिँ फेज 1 स्टडी हुन्छ. हेभिली क्यान्सर पेशेन्ट एन्ड युजुअली फेज 1 मा को जान्छ भन्दाखेरि हेभिली प्रिट्रिटेड, अरू सबै ड्रगहरू छैन, ट्रिटमेन्ट भइसकेको छ, नयाँ ड्रग आयो मार्केटमा, इट मे वर्क भनेर फेज 1 मा जाने हो. So what is population? We know what is population, but in research methodology, population is all the people who fit our study criteria. For example, if we want to know the height of the people in Nepal, all the adults of the country are healthy population. So if we want to find the height of female in Nepal, all female are population. It depends on the study, the scope of your study. For example, you want to know how many people have COVID by testing the antigen. So all people who are living in certain area like Kathmandu, they are your population. If you want to know who will win the 2084 election, everyone who has got voting right, that will be your population. So population is defined according to your research question. But doing any study in whole of the population will be very expensive, may not be practical or feasible. And if you see, they are of different color, like in population, it is a heterogeneous group. So what research usually does is it select a group of people, a small subset of people who are going to represent this population. So we are going to do all the experiment, all the observation on that group, and later on we will say that if in this group this thing is going to happen, in the population also the same thing are going to happen. If these people are going to vote for certain party, we think that whole of Nepal is going to vote that party. So sample is very important, because we are doing all the deduction and conclusion based on the small subset of population.
Any standard percentage, like what percentage we need to take a sample?
That I am coming. That is, sampling method is just, she asked like what percentage should be taken for sampling. So it is called sampling method. It is like how to select the sample from the population. This lady is sampling tomato. She is selecting the tomato. That is sampling, and that is blood sample. We know. For example, we have 5.5 liter of blood. We want to know what much sodium is there, so we don't take 5.5 liter. We take a sample and say that in the person also it is the same. There are two methods of doing sampling. One is probability, one is non-probability. It is a jargon. It is probability is like chance and non-probability is choice. So she is taking by choice. That blood which is going to the vial is by chance. So why we do sampling? We do sampling because I want to know the taste of this cake. This cake is very expensive and this is very big, so I can't buy it. Even if I can buy it, I can't eat all of it. I buy a small piece, taste it, and I know that this cake tastes like this. So this is why we do sampling. There are different methods of doing sampling, like probability sampling is by chance. Suppose there are 20 people, I write name of all the people, put it in a box and pull out 5. That is simple random sampling. Every person has equal chance of getting selected. That's simple random. Systematic is you follow certain system. Like I need 5 people, there are 20, so every 4th person I will take. Stratified is, but I want equal representation of male and female, or maybe I want equal representation from left and right side. So you make strata and take random sample from that strata. Cluster sampling is usually done in field trial, in which you don't randomize the individual, you randomize a center. Like there are 20 schools, you randomly select 5 schools and do study on those schools. It is more in the field studies. What type of sampling is this? No, she is not taking randomly, she is taking only the good tomatoes. So this is non-probability sampling. She is choosing the tomato, good one only. So there are different methods like convenience, volunteer, purposive, snowball sampling, by which you select only the sample which you like. It is easier to do. It is not bad, but it introduces more bias. For example, in a conference, there is usually a panel discussion. Usually the panelist choose. Usually the moderator choose the panelist. How he choose? He choose the panelist so that the output is going to come from it. So it is not. It is an example of non-probability sampling. So, for example, choosing the people based on purpose. The problem with non-probability sampling is internal and external validity. I will come. For example, why we need sample? To represent the population. She brings a kilo of tomato to her home, and can we say that the tomato in Kalibati is same as she brought? No, because she has excluded the unripe one, she has excluded the rotten one. So that is the issue with non-random sampling. But non-random sampling, it is easier to do, and many studies they use non-random sampling. So if you select a weird sample, you get weird result. So what is weird is, I'll go to the background. Most of the study on psychology, behavioral psychology is done in Western countries, and they are usually done by postgraduate and PhD students. So for sample, who do they select? They select undergraduate student. Usually the volunteers are undergraduate and they do behavioral research. And now what people have found is that there is already a book. Most of these sample, they are Western, educated, industrialized, rich and democratic sample. So the conclusion you are drawing from those behavioral research, they may not apply to the real world. So I just want to highlight that sampling is so important. If we select a non-representative sample, your answer is not going to generalize, because we are not interested in what happens to the sample, we are interested in what happens to the population. This is a book on weird samples. So now we understand that this is a good sample and that is not so good sample in research terms. So talking about sample size. Sample size is how small or how big should be this piece so that it represents that cake. The problem with small sample is if I cut it down, I'll only get the cream and it will not represent the taste of that cake. The problem with the larger sample is it is going to represent, but it is going to cost me more. So that is the balance between cost and the representation. And the sample size is the smallest number which is still going to represent the population. It will depend on so many things. One important thing is this is also sample, same size, but is that cake going to represent the taste of this cake? No, because the cake is different, the population is different, it is more heterogeneous. So sample size will depend on so many different factors. Like if in cake like this, maybe you need a bigger slice to know how it tastes. So the balance is between representation and the cost. So how is sample size calculated? The easy part it is usually done by a statistician, or if you are skilled enough you can do it, no harm. And it is always done before the study starts. The aim is to determine minimum number of subjects for the research. It is not the right number, it is the minimum number. And it depends on your hypothesis, the method you are going to test, like are you doing survival analysis, superiority, non-inferiority, the effect size, the power alpha and beta of the study, on all these things the sample size will depend. And there is something called type 1 and type 2 error. So if we don't do the proper sample size calculation, we may end up with higher alpha or beta error. This is self-explanatory, so I am not going details. And there are online tools. We use online tools. Like most popular one is sealedenvelope.com, in which you fill your parameters and it calculates the sample size. Or there are software like 𝗤𝘂𝗯𝗵𝘀. All these are for sample size calculation. But there is an easier thing, rule of thumb, like John Rosek, a statistician, he gave a rule of thumb. That is, the sample size larger than 30 and less than 500 are appropriate for most of the research. When you have subgroup, then a minimum sample size of 30 in each subgroup is necessary. For simple experimental research with tight control, successful research can be done even with sample size as small as 10 or 20. But remember, this is rule of thumb. You take help with proper statistician or someone who knows to calculate sample, but you can check it to see if it fits. Now coming to the last part, cancer research in low and middle income countries. This country may not have all the resources, all the manpower, all the time that is available in highly developed country. So there are certain type of clinical research, cancer research, which are better suited for this type of setting. So I'll list only some of them. One is MB-spective cohort studies. What is this? Is we said prospective cohort, we said retrospective cohort. MB-spective is you do both in a single study. Why? It saves time, cost, and make use of existing record. So this is being tried. Another is retrospective observational study. We have hospital record from which, without extra patient visit, with minimal cost, you can find answer to question like time to presentation, after how many months of symptom patient come to the hospital, why is there delay, how is the compliance. These things can be studied with the hospital record also. Like pragmatic or real world trial. in pragmatic trial, what you do is you don't prospectively divide the patient. In clinic, you are dividing the patient into different treatment arm, and retrospectively you see which treatment is working and which is not working. These are not as robust as the studies that I discussed, but these are practical, which can be done. Registry based study, we have cancer registry, we have hospital based registry, population based registry, from which you can do trends of disease, like we have high gallbladder cancer, we have cervical cancer, we can see the age, the geographical pattern, something like that. Cluster randomized trial is like you randomize a hospital, you are going to do this treatment in hospital of Kathmandu and another treatment in hospital of Pokhara, and try to see what is the difference. These are more practical, feasible, rather than randomizing single patient. Implementation research in how to deliver proven treatment, like adherence to treatment protocol. These research are being done in Nepal. Like we all have issues of follow-up, cost, workforce gap. This can be studied in our setting. Digital health and telemedicine, and the new thing is AI. AI is everywhere. So we can use certain tools like mobile phone, apps. Our mobile penetration is one of the highest in the world. Everyone is carrying 2 mobile, if not 1. So you can use those tools to capture data, and these are feasible even in low resource setting. Mixed method studies, Dr. Smith already discussed about this thing. So in mixed method, you do both qualitative and quantitative. You try to find what is the feeling of the patient, where is the treatment gap subjectively, and you try to measure it objectively, both in the same setting. So these can be helpful to find why there is delay in diagnosis, what are the barriers patient is facing, why they don't want to come to hospital, or why they are not following doctor's advice. These are answered better by the qualitative method. And one thing, the sample size and everything I discussed was about for quantitative. In qualitative, rather than the number, the feeling are more important. So you don't need a large sample size, you need more representative data. So this is a smart cat which understands statistics, and she is trying to explain or master that correlation does not mean causation, and she is not guilty. This is the power of research methodology. With this, I would like to end my talk. Thank you.